to welcome you all to today's tele-echo session. We'll be looking at the management of DSTB in HIV-infected adults. My name is Dr. Kandiwo, and I'm going to be your facilitator. We'll have our didactic presenter, who's also joining remotely. That's Dr. Chewe. Then we have experts that are going to join us and help us discuss today's topic. And these include Dr. Linus Mwinga, Dr. America Guji, Dr. Patrick Lungu, and Dr. Hethe. So I have seen that we have a number of connections. I think almost all the provinces are represented. Some have joined in from facilities and some have joined in as individuals. So I'd just like to welcome you all and we just thank you for making time to join us this afternoon. I'm just going to ask Nomsa to briefly give us a summary of what was discussed last week before we go into the presentation. Nomsa.
Thank you, Dr. Kandiwo. So my name is Nomsa Siamwanza. I work under Health Workforce for the 21st Century, project supporting Ministry of Health. So I'll give a brief recap of last week's presentation. So our topic last week was on retention in HIV treatment and care. And we had Dr. Mwango take us through. I must say that last week's session was very, very interactive and very engaging. And our objectives were defining retention. We also discussed on M&E, and we also looked at the common retention gaps. And Dr. Mwango ended up with giving us some strategies on how we can bridge some of those gaps. So I will define how we defined retention in the last session. So retention was defined as engaging regularly a patient in care with a view of achieving specific clinical or health outcomes. We also learned quite a few new terms that are used in retention, and I just want to remind us what some of those terms were. So we looked at retention. So retention is equal to or can be replaced by continuity of care. Then we also looked at lost to follow up, and the new terminology is interruption in treatment. Then the third one is defaulter, and the new term is patient who refuses or stops treatment. So I'll straight just pick out three summary key points or take home points that Dr. Mwango left with us. So the first one was retention requires appropriate managed patients engage in care for purposes of achieving well-defined clinical and health outcomes. And the other take-home point was retention gaps and interventions should be based on data-driven approaches, utilizing high-quality data from robust M&E systems. And lastly, there were more, but just for this purpose, lastly, one take-home message was most effective retention interventions require scaling up of DST models. Thank you.
Thank you so much, Nomsa, for that brief and straight to the point summary. So just to guide today, we'll start with the didactic presentation, then we'll go into our breakout rooms. And then at the end of the discussion of various breakout rooms, we're going to ask Western Province to share the summary of their discussion in under 3 minutes. So without wasting much time, I would like to call upon our didactic presenter, Dr. Webster Chewe. Dr. Webster Chewe, you may do a brief introduction as with the didactic presentation.
Hello, good afternoon. Hello?
Good afternoon.
Good afternoon.
Thank you.
Okay, thank you very much, Facilitator Dr. Kandiwo. Welcome to today's presentation. I must mention that I am not alone. I was actually given the task by Dr. Liusha, who is very much in this group. I don't know the boss, Dr. Liusha, if you want to say one or two words before I start. Okay, maybe Dr. Liusha has stepped out.
All right,
So I'll
go ahead.
Okay, so I'll start. So today we are looking at DRTB and some of the co-infections. And then we have some real life scenarios that we have come across in patients that we are managing for DRTB. Next slide. Okay, so today we have very few objectives. They are just 3. So we are going to look at the current DRTB and HIV preferred regimens. Okay. Then we are going to look at how we manage certain comorbidities in patients who have DRTB, and then we are also going to talk a bit about some of the biologics in DRTB. Why we chose biologic is because Dr. Liusha is a rheumatologist, so yeah. Then, so before we could begin, I don't know.
Sorry, Mr. Slumber.
There's so much feedback, yes.
Okay, I think on the poll question, but we'd just like to urge our participants to kindly mute your microphones. Galaxy S7, kindly mute your microphone, and the rest of the network. For all those joining in, please make sure you mute your microphones as you join. Thank you.
Thank you very much. So I don't know, facilitator, if we are going to, you are supposed to read out the poll questions, or I go ahead.
Go ahead and read them, then I'll share them from my end. I'll share the poll.
Okay, so the first poll is looking at what is the preferred regimen in DRTB treatment in Zambia. So I don't know, there is something that has popped.
Yes. So we are going to give our participants a chance to be able to poll and tell us what they think is the best regimen for treating DRTB in Zambia. So we have 4 options there. I know we have a lot of abbreviations, but we might have an idea. So which one do we think is the best regimen? Is it A, where we have BDQ, levo, linezolid, clofazimine for 6 months, and then a continuation phase of 12 months where BDQ is dropped? Or are we using B, where we have kanamycin with moxifloxacin, clofaz, ethionamide? Or is it C or D? I know they look similar, but let's give it a shot.
Dr. Kandiwo, we can barely hear you. Would you kindly be a bit loud?
Can you hear me now?
Slightly better.
Okay, so we have some, well, quite split thoughts there. I'm going to end the poll and then we'll continue with the didactic presentation and we'll discuss the results at the end. We can go to the next slide.
I have no idea that I go through there.
We can go to the next slide.
Yes, next slide.
So we have a second poll question. You can go back to the previous one. Question number 2. Okay, our second poll question reads, what is the preferred first-line ART regimen in Zambia? So we have 4 options to choose from there. The first one is TDF or TAF with XTC and efavirenz 400. Or is it B, ABC with 3TC and DTG? Or is it C, TDF, 3TC and NVP? Or could it be D? I'm pretty sure on this one, we are experts by now. Okay, so what do we think is our preferred first line ART regimen in Zambia? I'll give it a couple of seconds. You can see at least more than half of us have polled already. What do we think? Okay, so far 92% think the answer is D. So we're gonna end the poll now. We can go to the next slide. We have our third poll question, and it reads, DRTB co-infected with HIV with CD4 counts less than or equal to 50 cells per microliter. When can you start your ART treatment? So this is timing of initiation of ART treatment in someone with severe or advanced immunosuppression. So is it A, immediately? Is it B, after 8 weeks? Is it C, within 2 weeks? Or D, after 3 months? What is the recommendation from our guidelines? Okay, the poll is split with the majority thinking it's C, but we can still poll. We have like 10 seconds before we end the poll. Okay, thank you so much to everyone who has polled. We can continue with the presentation.
Okay, thank you very much for those 3 questions, as we are going to see. So I'll start with a brief introduction. So we all know that TB is caused by a Mycobacterium tuberculosis complex. And by complex, we mean that there are quite a number of species. We have Mycobacterium tuberculosis itself. It can be Mycobacterium bovis, Africanum, Microptic, Caneti, Capri, and many others. And we know that the natural reservoir is the human host, and then it spreads from human to human. And then this is the one which harbors the Mycobacterium tuberculosis. So when you get the primary infection, it undergoes what we call the natural history of infection. If it is that is just how it is spread. So when you get the aerosol droplets via inhalation, what the body does is that you can have immediate clearance of the tubercle bacilli itself, and you may not have any symptoms or any residue remaining. But if the immune system fails, then we have what we call the primary disease. And this primary disease, depending on the inoculum that someone has gotten, it can actually present with some signs and symptoms. But in the majority of the people you find that most of the primary disease, the body tried to clear it, and then it progresses to what we call the latent infection. And that is what we mostly have, the latent infection. And you can have this, some for the rest of their life, but for some, it may actually reactivate and cause active disease. And we find that in HIV patients, the reactivation of to active disease is actually more when you compare it to someone who was immunocompetent. And the literature has shown us that over 10% of the patients with HIV within a year will have latent TB being reactivated to active disease. Next slide. So when we look at the brief history, you find that in 1943, that is when they first recognized the therapy for TB when they discovered streptomycin. That was around 1943. And within, when they start giving, they said, fine, we have finally found a barrier, because previously there was very high mortality attributed to TB. But within the first 3 months, they started recognizing that resistance was being recognized after initiating the streptomycin. And this actually changed, that is like 5 years later, when they discovered what we call para-aminosalicylic acid, or PAS. And when they combined it with streptomycin, they saw that actually they prevented the emergence of drug resistance. Okay? So what do we mean when we say drug-resistant TB? So we mean that this is TB that is caused by an isolate of Mycobacterium tuberculosis that is resistant to one of the first-line anti-TB drugs. And by this first line, we mean isoniazid, rifampicin, parazinamide, diflunisal, and streptomycin. Okay? But this has also been complicated by HIV emergence, because we have seen that a lot of DRTB are actually being seen in people who have HIV disease, as we are going to see. Okay, and in 2019, we find that over 465,000 people worldwide had MDR-TB, or what we call the drug-resistant TB. Next slide. Okay, so why has TB become so difficult? I mean, I consider TB to be one of the most successful bacteria, and it is very successful. And why is it so difficult to treat or kill? It's because it has a very long generation time. When you compare it with the normal bacterium like Staph aureus, you find that it takes over 18 hours for just one mycobacterium to divide, as opposed to other bacteria, which may take even less than 20 minutes, okay? So this makes it very difficult for the drugs to have access to the mycobacterium and actually kill it. And then the other thing is that because of this very long generation time, we have what we call a principle of biorelativity, which shows that the longer the lifespan, the lower the fecundity, meaning that the ability to produce in abundance of offspring or new growth. So it is very low to produce the offspring. And this is what we see in TB. Also, we find that the capacity of dominance, it can stay for a very long time, and it is just dormant with very low metabolic activity, and hence very difficult for it to clear the mycobacterium, okay? And then when you look at the population when someone has TB, you find that they have very different population present in one person. So you find that some have resistant, some are compartmentalized, some are in a low pH and everything. So you need a lot of drugs for you to just kill these different populations. Next slide. Okay. In 2013, the FDA approved what we call the Gene Expert. And when this was approved, it has really helped in terms of catching a lot of people who have DRTB using the rifampicin resistance. So what happens is that this
Hello. So just a quick appeal to the network. Those joining in, please ensure your microphones are muted, and we also urge you to rename your devices. Thank you. We can go on.
Thank you, moderator. So we are saying that we have different genes where the mutation occurs in a mycobacterium, you find that for streptomycin, it occurs at the RPSA and RRS. So these are just like the binding sites where this streptomycin goes and work. And you find that when they are mutated, you find that it cannot work. And this is what they used to see when they were just using streptomycin monotherapy. And this is true for all these other drugs, the rifampicin, which we use in GeneXpert. We have the RPOB gene, and the isoniazid, we have two. And we find that when you have isoniazid, we have a CAT-G and INH mutations. It may also confer cross resistance with a thionamide. So when you are designing your drug protocol, or you are trying to give someone these MDR drugs, you should know that these are the specific genes that have mutated so that you can design a very good regimen. Next slide. Okay, so there's a lot of abbreviations. Sorry, I didn't put the full names, but I'll try to explain them. So when we look at the preferred DR/TB and HIV current preferred regimen for both DR and HIV, you find that for DR/TB currently, we are using a 6-month dose of bedaquiline, levofloxacin, linezolid, and clofazimide with a 12-month period of levofloxacin, linezolid, and clofazimide. Okay, and then the others are just alternatives. So I guess that was the question. That was the answer for the question that we had earlier on. So in case you cannot make that regimen, that's when you go to the other regimen. This is for the program so that we can have uniformity. Okay, and then for the first line ART, currently we are using TDF or TAF plus XTC and DTG. XTC, we know that it is either lamivudine or amitriptyline, and then the rest are just alternative if you cannot make the preferred regimen for the first line. Next slide. Okay, so what do you do when you have someone who's HIV positive, they are ART naive, and they have DR/TB? Okay, first of all, you have to know that any patient that comes and has DR/TB, we always screen for HIV. And when we find that they have HIV, of course, we know that you have to do what we call the CD4 count. Okay, so when you do your CD4 and you find that your CD4 is less than 50, in this one, we regard ART as agents, and we want to initiate ART within 2 weeks after the initiation of DR/TB. Okay. Why within 2 weeks is because the one we want to know that the CD4 is very low. Okay, the CD4 is very low. So we want to start ATT and not the other way around. Otherwise, we are going to have what we call IRIS. Okay? And if the CD4 is more than 50, for this one, you can say, okay, fine. We may delay ART for about 8 weeks, but not later than that. Okay? But there is an exception to this rule. For those ones who have stage 4 HIV, you want to start within 2 weeks for the obvious reason that I alluded to earlier on, okay? And what do you do in terms of the drug options? You can use any of those first-line ART drugs. The only thing you don't want to do is to combine efavirenz and bedaquiline, is because efavirenz reduces the concentration of bedaquiline, and hence you don't want to have a low concentration of bedaquiline when you have HIV, and hence you want to avoid a combination, but any other combination you can use. Next question. Next slide, sorry. Okay, so a brief natural history. I'm sure we are very familiar with this picture. So it's just showing us the natural history of TB. You find that in the first 6 months, we have what we call the acute HIV infection or primary HIV infection, where we see that when someone is infected, they become very much they are very high viremia in terms of the viral RNA, okay? And then after that, we see that they have this period, what we call the clinical latency, where there is prolonged suppression of the RNA, and then they may stay for this for a very long time until, if there is nothing that has been done to change the course, you find that within 10 years or so, most of them will progress to have constitutional symptoms and then have opportunistic infection, and then they die. But this can be modified when you give someone ART, okay? So this is what this is just showing. We can go to the next slide. Okay, and then there was this study which was done by a center of Haitian group, the JESCO in Haiti, which showed that TB development by 36 months, okay, was just 6% when you start your ART early as compared to those who were on the standard. So it was just emphasizing for the point that you have to initiate your ART early. Okay, you have to initiate your ART early in someone who has TB, and it was shown that it may delay the development of TB. Okay, we can go to the next slide. The same paper also showed that when you start your ART early, it decreased the rates of death and also the incidence of TB. Okay. So it was just extrapolating the same point. We can go to the next slide, please. Okay. So what happens when you have someone who's HIV positive and then they are on protease inhibitors, or they are on second-line ART with drug-resistant TB? You find that most of the DRTB that we use don't usually have interaction except for the first line, which is actually rifampicin. So you find that there has been negative interaction of a PI with rifampicin, limphamycin, and all those drugs. Okay, but when we come to the DRA drugs, you find that the drug-to-drug interaction occurs when you have by way of induction of the CYP450 enzyme, which you find in the liver, and then it may either reduce or increase the concentration of the drugs. So for the PIs, we usually want to avoid bedaquiline with a PI. If you cannot avoid it, then you have to watch closely. Remember, bedaquiline is one of the first-line drugs that we are using in DRTB. And one of the side effects is that it can cause what we call arrhythmias. Okay? So if you cannot avoid a PI, then you have to make sure that you are doing your ECG regularly so that you don't cause any cardiac arrest. And for those who are on delamide, well, there is some interaction, but you just have to make sure that the patients don't have low BMI, because it also increases their side effects when they have low BMI or they have low albumin levels. So this is the only thing that we watch out. Otherwise, for the other drugs, there is no major interaction that occurs. Next slide. Okay, so what happens when you have someone who has HIV and they also have hepatitis B? Okay, so for those ones who have hepatitis B and HIV, we know that not all active hepatitis B infections require immediate treatment. Okay, It doesn't matter whether you have hepatitis surface antigen, which is just reactive, you have to observe and follow up. But there are caveats to this, okay? We have what we call the APRI score, the AST to platelet ratio index, okay? So we have what we call a preferred non-invasive test to assess for the presence of cirrhosis, or we use the APRI score to score and make sure that we get the value. And the APRI score is calculated, I don't know if people are able to see, the AST level stroke AST upper limit of normal divided by the platelet count times 100. So when this one is more than 2, it is highly suggestive of cirrhosis. And if the APRI score is less than 1, you rule out the presence of cirrhosis. Between 1 and 2, it is the gray area, okay? We can go to the next slide. Okay, so when you have an APRI score of more than 2, you want to treat the hepatitis B. Or if you don't have that, if you have high ALT levels with a very high hepatitis B virus replication, and this is denoted by the DNA viral load of more than 20,000, regardless of hepatitis E antigen status, you want to treat the patient for hepatitis B, okay? And if this is not available, persistent elevation of ALT may warranty you that you have to treat the hepatitis B, okay? And the preferred regimen is TDF-ART regimen. So we use the TDF-based regimen. For those patients who are already on TDF and they have hepatitis, there is no need to worry because they are already catered for. But for those patients who are already on other modalities, then you have to think twice and either reintroduce TDF or look for other regimen that might work. We can go to the next slide. Okay, so now what happens when you have hepatitis B, HIV, and DRTB? For this one, we are saying that, okay, lamivudine and tenofovir TDF or TAF, they have active against hepatitis B. So if they're already on this one, you are good to go. You can use your first line plus your first line DRTB regimen, okay? But if you cannot use your lamivudine or anything else, you have other options like entecavir that you can use according to the to whether someone has compensated or you can adjust the dose. But you do not have any change in the DR regimen. You can use the first line because there is no other interaction that occurs. So this is how we can treat someone who has hepatitis B, HIV, and DRTB. Okay. We can go to the next slide, please. Okay, so this slide is a bit loaded. I didn't know how to make it a bit better. So when you have someone who has HIV and then they are ART naive, they have DRTB, they have hepatitis B, and they have hepatitis C. So now you see that now it is becoming more complex. Remember that for hepatitis C, the treatment that we give is to cure the disease. It is because hepatitis C does not achieve, as in it does not insert its genome into the nucleus. It does not integrate its DNA into the host DNA. So the aim of treatment for hepatitis C is to cure it, unlike HIV and HBV, which goes and integrates itself in the human genome, okay? So what do we mean when we say cure for hepatitis C? We mean that you have undetected hepatitis C virus RNA 12 weeks after completion of antiviral drugs, okay? Or you have reached what we call sustained viral response, okay, after 12 weeks of treatment. And we have various drugs that we use. The problem is that we rarely look for hepatitis C. At least for hepatitis B we can, but for hepatitis C, I couldn't find any literature which showed the prevalence among DRTB patients in Zambia. But we postulate that it is very high, especially in those who have also HIV. Okay? So the major interaction that is there between the DAs and ARVs, well, you just have to, we can go to the next slide so that it shows which ones shows the major interaction that occurs. Okay. So you can see that it is also a very loaded, but I can show you that you find that most of the first line, since we are using the Lutilgravar, we can actually use with the drugs that we use in the treatment of hepatitis C, with no major interaction. Okay? With no major interaction, apart from maybe drugs like efavirenz, you don't want to use it with Biopasiva and these others, okay? But most of the first line that we are using, you can actually use it with the first line that we use to treat hepatitis C. So this shows you that at least we have a leeway without worrying about the interaction that occurs in some of these ART and the DRTB drugs that we use. Okay? We can go to the next slide. I'm sure they will share the slide so that you can have a look during your free time. We can go to the next slide, sir. Hello? Can you go to the next slide?
Are we able to move to the next one? Okay, thanks.
Okay. So now, what happens when you have hepatitis B, hepatitis B, HIV? I think we can go back. DRTB, and you have renal failure. Okay. So when you have hepatitis, it's a previous slide, sir. The hepatitis B, we know that we are using tenofovir, lamivudine, or FTC, which is active against hepatitis B. But the problem now is that we have renal failure. Okay. And it has shown that for those who have hepatitis B, if we haven't used the TDF regimen, the resistance is actually very high, especially in the first year of treatment, to up to about 50%. So what do? You can either use your TDF clearance and give it accordingly, or if you change to your ABC, you can, especially if your clearance, if creatinine clearance is less than 50, you need to definitely change to ABC. But if it's more than 50, then you can dose your TDF according to what I've shown below. If it's more than 50, fine, you can use the normal dose. But if it is less than 10, we usually want to avoid. But if you have someone who has CKD and they are undergoing dialysis, then you can still use your TDF, but you have to give it after someone has undergone dialysis, because we know that TDF is very nephrotoxic. Okay? Why we want to use TDF is because if we don't use TDF in the treatment of hepatitis B, the chance of the hepatitis B becoming resistant is very high, especially in the first year. It's even become over 90% by the time we are hitting 3 to 5 years. So this is what we want to avoid. I don't know if in the audience we have people who have had such patients who have hepatitis B, HIV, DRTB, and they have renal failure. We may find that there are very few, but they do occur, okay? Next slide, please. Okay, so I should be finishing very soon. So we have medicine that we call biologics. Okay, we have biologics that we have. We know we live in a global world, and you may just find that you have patients who are on these biologics, and then they come. What we know that the biologics, we use it to what we call suppress the immune system and reduce the inflammation. Okay, so if someone is on these biologics, and when we say biologics, they are just medicine like any other, but they are special because we use it to modulate the immune system. We have drugs like abatacept, adalimumab, and many other, as shown in the presentation. But what we recommend is that before you initiate someone on these biologics, you want to screen them for TB. This is because it actually reactivates, because you know that it is an immunosuppressant. So the TB reactivation is very common, okay? And for the other reason, because we use these drugs for a very long period of time, and therefore, for someone to have TB, it is very common, okay? And it may actually make the TB infection very serious. It doesn't matter whether it is susceptible TB or DRTB, okay? And they have worst outcome, because it is either the TB that will kill them or the infection that you are trying to suppress that will kill them. So these are some of the things that we say, okay, fine, we should alert the people as we become more global and as we start accessing these nice drugs, okay? Next slide, please. Okay, I don't know if Dr. Liusha is around to say one or two things before I could conclude.
Dr. Liusha, are you with us on the call? I think you could go through the summary key points, and then we can ask him also to say one or two things.
Okay, thank you very much. So what we are saying is that we have preferred regimen that are just used for the convenience of both the uniformity and also for the program, so that we avoid ambiguities, and also that the DRTB and comorbidities are common, and sometimes they may present as a very big challenge to manage. And you find that most of the time, the complicated cases are usually referred to the next level of care, okay? And we should always screen for HIV in all patients that have DRTB. And we should all be aware of the use of biologics in people that have DRTB. I think this is where I end my presentation.
Thank you so much, Dr. Webster, for that very detailed and elaborate presentation. We've touched on a number of issues, starting with the treatment of the DRTB itself, the preferred regimen in our patients who are on ART, also what we need to look out for in patients with advanced immunosuppression, and the number of drug-drug interactions that we also need to monitor for. I think before we go to the poll questions, we'll ask Dr. Liusha, who is a co-presenter, in case there are one or two things that you might want to add, Dr. Liusha.
Yes, Dr. Kandiwa, I hope you can get me now.
Yes, we can.
I was struggling to come in. Unfortunately, I was muted by the host throughout the presentation. So that's the reason probably I didn't chip in. But maybe we can just go back. There are a few slides I wanted to comment on. Those slides, if people can remember, where we were showing the natural history of HIV. And then there are some studies which were showing the progression in terms of likelihood of mortalities for those who are not treated. So just the emphasis, if you saw, I think in the last diagram, it was showing that there's a 50% chance of mortality if we delay ART initiation for our patients, whether they have susceptible or drug-resistant tuberculosis. So it is imperative upon all of us as caregivers to make sure that all the patients, once we diagnose TB, we have identified HIV infection. We should start them on TB treatment, control the TB, and immediately put them on ART as soon as it's feasible, because we know that high HIV viremia itself is very destructive actually to a lot of organs, especially things like the kidneys, the liver, and so on. The other slide I wanted to comment on was on the issue of TDF in patients who have TB or where they have co-infection with hepatitis B specifically. And the issue of when do you decide to give the dosage for TDF for those who are dialyzing, whether they are on hemodialysis or they are using peritoneal dialysis. So the advice is to medicate after they have undergone their dialysis session. And the reason is because TDF is dialyzable actually. And that's the main issue, that we want you to dose or to encourage the patients and educate them that if they are undergoing dialysis, let them take the TDF after the session. Then I think I saw on the chat, Dr. Kevin Zimba asked about availability of viral loads for hepatitis B. Unfortunately, I think in the public sector, we are struggling with that one. But there are quite a good number of private labs, especially except that the cost is quite prohibitive. But probably we can always strive that if we have clients who can afford, we can encourage them to have the hepatitis B viral DNA load, because it gives a lot of information in terms of your targets for treatment. When do you decide to say, I have treated someone adequately apart from doing the antigen and doing looking at their AOT and AST and other parameters. I'm sure, I think the teams in infectious disease, I have seen Dr. Sufrosh on the call, Dr. Kandio, yourself, you're there. ID specialists, you will be able to help us with some of these conditions. So thank you very much. I think those are my few words.
Thank you, Dr. Liusha, for your input. You have reminded us once again that TB is still a very big burden amongst our peer HIV, and it's still one of the leading causes of mortality. So at this point, I think we can go to the poll questions, but as we do so, I would like to invite 2 or 3 questions from the network regarding what has been presented so far. Do we have any questions for the presenters, Dr. Liusha and Dr. Chewe?
Dr. Kandi or Dr. Mwinga here?
Yes, Dr. Mwinga, go ahead.
I think there was one interesting question in the chat that was asked with regards prevention, that like we give, for drug susceptible TB, we are giving INH or 3-HP as prophylaxis. So someone was asking for DRTB contacts, what option do we have? Over.
All right, thank you so much, Dr. Mwinga. So Dr. Liusha and Dr. Chewe, would we like to respond to that question? What do we give for contacts of DRTB patients in terms of prophylaxis?
It's a very loaded question, I think, Dr. Kandio.
Yes, it is actually. Yes.
So colleagues, unfortunately, I don't think there is any prophylactic monotherapy or dual therapy that you can give to stop yourself from getting infected from DRTB. But the prevention that is available is, number one, to identify in the community, in the health facility, all those who have DRTB, put them on treatment, and make sure that all their contacts are traced, diagnosed, and treated as early as possible. Number 3, primary universal prevention, I think, is paramount. And here we're talking about issues of encourage the patient to mask with a surgical mask, for example. The contacts, if the people who are caring for the patient, whether it's healthcare workers, the next of kin, whether it's a wife or husband or children, encourage them to get hold of an N95 mask as they get in contact with the patient on a day-to-day basis. But most importantly, I think it comes back to the issue of contact tracing, community surveillance, and make sure that we integrate the community and identify all these people and treat them. Because the key is really to prevent emergence of resistance by treating all susceptible TBs so that we don't get all this primary and secondary drug resistance. So Dr. Kandiwo and the people who asked, I think just a brief comment on that.
Yeah, just as an addition to that one, I think
yes, Dr.
you need to take note of the sensitivity patterns or the resistant patterns of the primary patient. You just take note of that. And then for the contacts, you need to enroll them in a rigorous follow-up program so that at regular intervals, you're actually getting to review them. You ask them about the TB questions and offer all the available investigations. Should they at any point actually turn out to have the TB, you can actually start the medication. If you had the culture results, you can actually tailor the regimen based on the initial or the sensitivity patterns of the primary case. If not, you can actually just give the standard DRTB treatment regimen that we have. Over.
Thank you so much, Dr. Liusha and Dr. Mwenga. As Dr. Liusha said, that was a loaded question, and I'm hoping that we've been able to pick one or two things. We've seen here IPC measures are key and contact tracing, and we've been guided if we are to initiate DRTB treatment in contacts, what would be the preferred drugs. So I've seen there are 2 hands from Dr. Zimba and Phineas HNP. Let me just briefly read a comment in the chat box that was from David. David was asking if TAF can be used to treat hepatitis B. And the response from Dr. Folosh is that TAF is as effective as TDF for hepatitis B, and it's a good alternative. But remember also, we need to look at the creatine clearance. So Dr. Kevin Zimba, can go ahead with your question, and then Phineas, and then get some responses from the experts.
Okay, thank you, Doc, for that. For the opportunity to speak. I think I'll comment on 2 things. There's, I think, the same prophylaxis for MDR-TB, the use of the levofloxacin. I think that one should be left to consultation with the clinical expert committee rather than just prescribing it routinely. Remember, the quinolones are one of the drugs that are mainly relied on as we're treating MDR patients. Levofloxacin is one of them. Then I'll make a comment on the hepatitis B. I asked that question on how readily available is it to have hepatitis B viral load and hepatitis B antigen done in helping us make a decision when we're going to treat our patients. Because clearly, most of the time when our patients who come to public facilities are met, we have a patient who's got hepatitis B, surface antigen positive, and you're stuck, you don't know what to do. So I think we need to develop guidelines that speak with the most common setting in our country. I know we have a session on hepatitis B, but we can be thinking around it so that we create guidelines that allow the people who are working on the ground be able to work easily without difficulties and looking for expensive tests are not available. Thank you.
Thank you.
So maybe moderator, may I just comment before my thought process disappears? So Dr. Zimba and the rest, you may wish to know actually, I'm not sure exactly, but we have some of the guidelines which advises all our healthcare workers to rely just on the surface antigen positivity as well as the levels of the surfaces, ALT and AST. So there is already some guidance just to help in a resource limited setting where you are not able to do both the viral load and the E antigen, but you can actually rely on the presence of a hepatitis B surface antigen as well as a deranged and elevated AST and ALT above, say, 3-fold rise from the upper limit. You are, I think, allowed to put someone on treatment just on that basis. Thank you.
Thank you so much to the experts. I know that here we've touched two very big topics. There's DRTB and there's hepatitis B. I think we'll bring a session on hepatitis B so that we can discuss a bit more in details. So for today, I would like us to take the discussion back to DRTB. And I think we had a hand from Phineas. Is Phineas still on the call? In the meantime, I will read a comment. One of the questions in the chat box was, how do you manage a client who you suspect to have DRTB, but gene expert is showing no rifampicin resistance? And then when you do microscopy, you keep on seeing your bacilli. And the guidance that we've gotten from Dr. Kanguji is that for patients who continue to be smear positive, we need to request for LPA, that's line probe assay, culture, and DST. So it will inform you of resistance to other drugs so that you can revise the treatment as needed. Okay, so Phineas, go ahead, and then we'll be going into our breakout sessions.
Okay, thank you very much. I think the question I wanted to ask has been answered. It was concerning the use of TAF. So it's been handled. Thank you. I had to drop my hand.
Okay, thank you so much. If we don't have any burning questions, so is it Kashikura Kazadi? I think that'll be the last question we're going to take before we go into our breakout sessions, but I would also encourage you to read through the chat box. I think our subject matter experts have been very active in responding to most of the questions, and I'd like to commend them for that. So Kazadi, you can go ahead with your question.
Oh, good afternoon again. I have a concern concerning the timing of initiation of ART on a patient who have just initiated on DRTB treatment. For those who have got a CD4 count less than 50 cells per microliter, it is said we have to initiate ART within 2 weeks. Wouldn't it be better to be a little bit more flexible within 2 weeks when the TB treatment is tolerated, rather than coming out very strong, say less than 2 weeks we initiate? Isn't it too rigid a statement? Thank you.
Thank you so much for that question. Gerard, kindly mute your microphone. Gerard, thank you. So we have a question there regarding the timing of initiation of ART. We are saying within 2 weeks. Are we being rigid with that, or should we just say as soon as TB treatment is tolerated? Dr. Liusha, would you like to comment on that?
Okay, so let me just see. I can't, this was, I think, slide number 14. If you go to slide number 14, then one of the slides we prepared is an extract from the New England Journal of Medicine, and it shows a Kaplan-Meier estimates of survival without antiretroviral therapy among 408 participants in a standard treatment group. And you'll find that the progression or likelihood of mortality, or what you may call probability of survival without ART, it declines so rapidly over a very short period, actually. And hence, that's why the expert recommendation is that as soon as it's feasible, you should initiate, and preferably within the first 2 weeks. Because remember, a very high HIV viral load, let's say someone with 1 million copies of HIV1, the chances of them developing encephalitis, developing acute liver injury, or developing acute kidney injury are very high. So the more you delay, the more you wait, the higher the probability chance that they will have multi-organ involvement and damage from HIV itself as an acute viral infection. Okay. And so your aim is to try and drop down that viral load as quickly as possible, because you're already taking care of the DRTB. And mind you, for the severely immunosuppressed, preferably would want you to manage them in the facility and not at home, so that you're able to take control and take charge of any adverse complication that may arise. And so you may be able to handle some of the issues related to poor tolerance to the drugs, as well as some of the adverse effects or reactions that may occur. So I think it's a very strong recommendation. And when you look at medical studies, they'll still show you that actually the recommendation is quite strong in terms of evidence-based practice. Thank you, Chair.
Thank you, Dr. Liusha, for that. In the interest of time, I would like us to just quickly go and look at the poll questions in the next 3 minutes, and then we'll get assigned to the breakout rooms. So we can upload the presentation and relaunch the poll so that we quickly see if we've learned one or two things. Okay, so quickly, our first poll question has been relaunched. What is the preferred DRTB regimen in Zambia? So we have 4 options there. Okay, so we can already see that the majority are going for A. And I know that some of us may have joined in late, so we may have missed this, but I think the majority are leaning towards option A. So share the results. And so we'll just ask quickly, in 10 seconds, Dr. Webster to comment on this.
Okay, interesting that some people are still choosing B. So the answer is A. We are using bedaquiline, levofloxacin, linezolid, clofazimine as our first line for the first 6 months. For B, this one is no longer in our guidelines. It was through before 2019, somewhere early 2019, but we are no longer using kanamycin as part of the treatment for DRTB. And then C and D, we are using if we don't have A. So C and D are alternative regimen. So this is all I had to say.
Thank you so much, Dr. Webster. I think we can just quickly look at the second poll question. Just in 30 seconds, what do we think? Wow, it's interesting. I can see we're already polling. What is the preferred first-line ART regimen in Zambia? So far, no one's speaking B and C. What do our guidelines say? Okay, so we have an idea. And Dr. Webster?
Well, this one I can see 96% parts.
Yeah.
For A and B, we are using them as alternative to D. If we cannot use D, that's when we go for A or B in special conditions.
Thank you so much. And then we'll just quickly look at the third poll question. And the third poll question reads, DRTB co-infected with HIV with a CD4 count of less than 50 cells per microliter, when would you want to start ART treatment? So we have 4 options there. Immediately, is it after 8 weeks? Is it within 2 weeks? Or is it after 3 months?
Wow. I'm Dr. Liusha Namakando to explain on this one. The answer is C. Yeah.
Thank you so much, Dr. Liusha and Dr. Webster for the presentation. We can see that learning has taken place. I just call on the IT team now to assign us some breakout rooms. And after we're done with the discussion of breakout rooms, we're going to have Western Province share their discussion. So if you get a prompt to join a breakout room, you can just click where it says join.
They are having challenges.
Network, yeah?
Hello.
Hello, IT team. We've been brought back to the main room. I don't know if that was an IT error.
Hi, we're back in the breakout rooms.
All right, thanks.
Welcome. Hello. We know Mavombin. MK. Okay.
Dr. Kandio.
Mute yourself. Okay, no problem. Okay, no problem. Okay, thank you. Thanks. Which room should I put Dr. Mia? Dr. Mia. Southern. Okay.
Chaton, are you looking for the presentation?
Hi, Doc. Hi, Mr. Silomba. Is it who's supposed to share from this region? I'm currently assigning people to breakout rooms, so I'll be unable to share the presentation. Who's supposed to?
For Lusaka, we have Dr. Malilwe.
Okay.
Muhuma as the facilitator. The experts, we have Dr. Kelvin Zimba, Dr. Webster Chewe, and the presenter is Dr. Mwila Mwelwa.
And for Eastern? Hello, good afternoon. Hello.
For Eastern Province, the facilitator is Dr. Goodson Mpumba. The case presenter is Ali Bespiri. The experts are Dr. Linus Mwinga and Dr. America Guji.
Yes, I think we've been put in the Long Province. I think we are in Lusaka, and it's us presenting for Eastern Province.
Okay. Let me move you Simwinga Chasefu.
Yes,
Thank you.
exactly.
Thank you.
Good afternoon, Doc. We are still waiting to be assigned.
I think equally here, we've been told to say we wait for a prompt to join, but there's no prompt that has popped up, they say.
And they want to hear the others.
Wendy, could you send Dr. Chungolo to Western Province? Because he's supposed to be one of the experts there.
I'm getting Eastern. Yes, sir.
Chair.
Yeah. Hello? Hello?
Simuinga here, we are still waiting. It's us presenting in Eastern Province. It's us who was the case for
Okay,
Eastern
okay.
Province.
Which room are you currently in?
Sorry?
Which room
I
are you
think this should be
Lusaka.
Lusaka, the main hub.
Okay,
Yes.
okay, thank you. My apologies, there are about 100 or so people I'm trying to assign, so it's, let me just quickly do that for you.
Admin, could you please add Dr. Chungolo Peter to Western Province as one of the expert person there?
What's his name again?
Dr. Peter Chungolo.
Peter Chungolo, to which room?
Western Province.
Okay.
The creatinine, we may wish to know that, to note that the earlier one was 359.52, and the EGFR was about 16.2 mils per minute. Okay. And then later on the 27th of January, creatinine was 111.52 micromole per liter, and the EGFR was 66.9 mils per minute. So our questions, the questions from the facility are as follows. What could have been done to detect TB early in this client who was virally suppressed? The second one is, how can we approach the drug therapy combination of ART and ARVs in patients who may have AD? And the last but not the least, is there any other supportive care we can provide to this client to ensure survival while on treatment for TB and HIV? I would also just like to urge the network that please let's try as much as possible to, due to limited time, to answer the questions that we have at hand. And maybe if the facility is joined, maybe we could limit the number of questions that we ask just to clarify. Then we'll have our expert come in and give in his insights. Hello. Okay, shall we? Okay, you can unmute if you have a question, or you could raise your hand, or any contributions to the questions that are posed by the facility.
Okay, thank you, Dr. Banda, for that presentation. My thoughts on question 1 would be, I understand that in the patient history we looked at, we got the an item that the patient was started on, was given TPT. And I take it that that was after a symptomatic screen for signs and symptoms of TB, isn't it? So I think how we could help maybe to have early detection of TB in this case would be at every visit when we're seeing these patients in ART, regardless of whether they are very suppressed or their CD4 count is high and so forth, we need to actively screen them for TB. So I think this case is a very good eye opener for me. In my just looking at it, I think that it gives a lot of queries in the way things were done. We understand that the reason why we gave TPT that was about 5 months ago, I think was based on symptomatic screening. But if the patient completed the treatment and then ended up having TB, I think we should have possibly looked at the possibility of whether this patient was taking TPT correctly or not. And also the issue of this patient drinking could possibly have influenced adherence to TPT and so forth, and could have resulted in the patient contracting TB at the end of the day. And those are my thoughts.
Thank you so much, Dr. Ndlovu. Any other thoughts? We have 3 questions here. Let's interact, team. Okay.
Dr. Banda.
Dr. Banda. Yes.
This is Dr. Smenda.
Yes, Dr. Smenda, you can come through.
I think my contribution on the number 3 is that I didn't say clearly the full blood count, but I think we must quest and try to do it, because the anemia is so severe. It would be very helpful, even though the machine was down at the time, to have it done so that we could see the other blood lines. Is this only anemia, or the other blood cells are also affected, to rule out other possible pathology in the bone marrow? I see that it was not done later on. Eh?
Oh yeah, it was only done a little bit later, and it was at 6.9 grams per deciliter. And the MCV was 94, MCH was 26.3.
I see, 94, but then we didn't have the white blood cell line. What was the picture like? Was it normal? That
so
line?
Those were actually, unremarkable. So they were normal. The white cell count and the platelet counts were all normal. That's why they were left out.
Okay, that's good.
Okay, Dr. Mamba, you wanted to come through?
Yes, Doc. Maybe I'll go back. Okay. Regarding the first question, I concur completely with Dr. Ndlovu. So let's just get keen interest when we are screening client. This is an appeal to all the clinicians in the clinic, the screening room. Because in HIV client, the cough of 1 day is already suspicious for TB.
Maureen Banda, kindly mute your mic.
Okay, so I was saying a cough of 1 day in a HIV client is already suspicious of TB. So let's just screen with emphasis these ART client whenever we are interacting with them. And then on the second question, how can we approach the drug therapy combination of ATT and ARVs in patients who may have CKD? I think on this one, this is what we are from learning during the presentation. So it's very much important that the creatinine is done, and regarding of based on the value that we are getting from creatinine, then we can see how we can readjust the treatment for this client who may probably have chronic kidney disease in HIV. My submission, thank you.
All right, thank you so much, Dr. Mamba. I can see Dr. Hess is really itching to come through. Dr. Hess, you can come through.
Thanks so much, Dr. Banda, and I just wanted to say it's a great discussion. I just wanted to jump in on question 1. So I think Dr. Ndovu was mentioning that we should screen for TB at every visit for symptoms and be really aggressive. And I think that's really an important contribution. And I just wanted to highlight in November, we see that the gentleman's BMI was 17, his weight was 43. And so actually, just to remind us, you know, the BMI less than 18.5 is compatible if someone has sort of low-grade fever or diarrhea or a history of weight loss, is compatible with HIV wasting syndrome, which is a stage 4.
Very high. So it would have been important that we actually do the gene expert to be followed and then followed through with a culture for TB, as we've actually rightly been doing the cultures. I mean, we've been rightly doing the viral load for the HIV to assess response to treatment. So with regards downsizing, it's really different.
Guidance usually as clinical expert committee, like anyone who remains smear positive month 2 or beyond, even as you send samples to the referral laboratories, do a gene expert. Remember that your initial gene expert was susceptible. So at month number 2, month number 3, you're still getting smears that are positive on microscopy. There's actually every reason that you should start with the gene expert at local facility as you send other samples for culture and DSPs, LPA, and so on to the referral labs. Remember that the turnaround times for our referral labs can be quite frustrating sometimes, but once you get your gene expert result at month 3, it may actually show that this is DRTB, and you may still proceed to treat someone using the first-line DRTB arrangement. And from practical experience, I've had such patients on the upper belt. Usually that's what we advise everyone, and that's what we've been doing. Thank you.
Thank you very much, Dr. Liusha. Indeed, you've summed up question 2. Just as a way to invite any other last comments, maybe.
I think, Dr. Moma, you actually bring out a very important aspect in terms of our management. In the care of our patient, there's a point where we miss the opportunity to make a diagnosis of TB in this patient. And so this speaks very clear out to what we do in our consultation room, or screening room. Let's just not tick those questions in our smart care. Is there a cough? Is there a fever? Let's please interpret and use that information that we are generating to help the patient and prevent other people from getting infected. I think every patient is screened for TB, like this patient was, but we didn't use that information that we had to make a diagnosis of TB early enough in our patient. I think we missed a big opportunity in 2019 to make the patient decide on treatment. And this reminds us of how slow growing the TB bacilli. We had the presenter in our didactic actually mentioned that TB is a very slow growing bacilli. And that's how come our patient 1 year later, the patient is still alive and having those problems. Thank you.
Okay, thank you very much, Dr. Kevin. Do we have any other comments before we go back to the main room?
You know, the transfer letters, to what detail to what extent do you ensure that your transfer letters actually have sufficient detail for the next facility to make an informed decision? An example here is one patient was transferred, I think, from one facility to Lundazi or the other way, but Lundazi couldn't figure out what regimen the patient was on, which doesn't make sense to me. And also aspects of strengthening communication between the health facilities so that we can definitely be based at Lundazi, but coach a safe one, say, hey, your transfer letter is inadequate. Can you give us these details? We need them to make a decision. So those are just additions from my end. Oh, and maybe one more thing, and I think Dr. Mwenga and somebody else touched it, is the aspect of utilizing peer-patient pairing. I think for such patients, no matter how long they've been on treatment, I think these are people that can be attached to a particular peer to support them until they are better. Thank you.
Thank you very much, Dr. Kaguzi, for that addition. Also, indeed, what we have noted on this client, on this patient, is that we do have some systems that need to be strengthened, like we have said. I think to begin with, we took long for us to identify that the client had TB. Our presumptive registers, like Dr. Kaguzi has said, how well documented are they, and how can we miss a well-documented presumptive case which has not had the spectrum submitted? We also note that also in issues of transfer, we do not have sufficient details because the facility did not receive or did not know on what regimen this client was. And we also note that even in the diagnosis, we should we encourage the team to ensure that GeneXpert was supposed to be done as opposed to sputum microscopy, because this is a possible candidate for DRTB. And also EAC would like to know and understand the issues pertaining to the skills of the staff that are doing the EAC, so that we ensure we see how we can improve that. Also, on the other hand, the wife is taking medication, is on ART, and we would like to get more detail if this woman, we can utilize her. If she's adhering and she's also suppressed, she could be one of the bodies that we can use. Otherwise, those are some of the issues that have been raised, and thank you very much. I think in a few seconds, we'll be getting back to the main room. Thank you so much. And thank you to our experts. Thank you for everyone who has contributed to and asked questions. See you on the other side.
Today, we're just going to ask the Western Province team to give us a summary of the case, what was discussed, and the recommendations, so that the rest of the network can also learn from the discussion in Western Province. Dr. Himawala, you may take it up. You can give us a summary in the next 2 minutes of what the case was about and the recommendations made.
Okay, thank you so much, Dr. Kandio. This is Dr. Himawala from Western Province. Today we discussed a 41-year-old male who presented to our facility about 5 days ago, and he came in with a 5-month history of constitutional symptoms with classical TB symptoms: weight loss, cough, night sweats, and also reduced appetite. Also, this client was tested for HIV and was found to be positive. It was actually a community referral, so they were tested and found positive. On examination, we found reduced air entry on the left lower zone. And on tests that we did a chest X-ray, and we found homogeneous opacities and obliterated lung markings, especially on the left side with pleural effusion. And there was also homogeneous opacity on the right upper zone. On GeneXpert, MTB was detected and it was low. So this client was managed as a case of PTB in a newly diagnosed RVD client. So they were initiated on ATT. So on the discussion questions, the things that we tackled are the following. So we reminded ourselves that we needed to initiate this client on ATT first, and later on initiate ART within 2 weeks. Of course, taking into consideration the CD4 count. However, it's unfortunate that in our case, we did not have reagents for CD4 count, so it wasn't done. But I think the take-home message is that within 2 weeks, if there's no other concerns, like opportunistic infections or anything that could be worrying, we need to start this client as soon as possible on ART. Then the other points of discussion were the other tests that we could possibly do for this client. And we saw that we could have done also urine lump to just confirm diagnosis of TB. Other supportive tests could be hepatitis B surface antigen, RPR, serum CRAG, just to rule out opportunistic infections. And also, if this client has no opportunistic infections, we can actually put them on prophylactic fluconazole, that is for 8 to 10 weeks. And then also the other point of discussion was on strategies for community sensitization. This client, we realized that he's a married man and also has 3 children. So we needed to do intensive case finding and contact tracing, starting from the people that he's staying with and also the other people that he would have been in contact with. And also it was emphasized that we need to do a lot of community and sensitization and education, so that ability of helping facilities to identify TB cases and any suspicious clients that we may have in our communities. I think in summary, that's what our case was about. Thank you.
Thank you so much, Western Province team, for giving us a summary of what was discussed in your group. I think we can all agree that today has been a very rich discussion. I'm hoping that we've learned 1 or 2 things that we'll be able to implement in our various facilities. I'd just like to thank the presenters, Dr. Liusha and Dr. Chewe, for being available and giving us the didactic presentation. And as you could see, they were showing us a lot of data. I'd like to thank the subject matter experts as well for creating time to help us discuss the cases today. I do not have any announcements. Nomsa, you may let me know if there's any, but just to mention that next week, we'll be discussing DTG transitioning.